Yeah, a lot of people have it as, I guess it's done now. There's a lot of schools that also do for third-year rotation.
You could get that, Steve.
So for us,
I'm sure.
ultimately, they will get emergency, obviously, well, for me, like, so that's reality, but they like to change the current third years can choose, a lot of people go into them so that they can choose to do one of their electives.
Yeah.
I do my physiology, so, and then a couple
Yeah, right there.
I won, and then got paper, and then I scheduled the other one. I have a lot of, like, unopened or open.
Yeah.
Or it's easier that way, but sometimes it's like when you then start looking at later drops. Yeah. It wasn't a lot for me. So I was saying they're doing that. So I didn't schedule. I scheduled just 3 hours. Yeah. But in terms, and then, but for me, people don't hear about the hospital. I give you like much anxiety. I have to, I don't like to be a planner, but I really do things with like, any outpatient, if you just go. A lot of them. This time of year, so for the end of the year, yeah. So some of them I'm gonna do for the end of the year.
On here. Let's just wait for Pavon to get started.
We can start. And he's a night doing, send Chris. Oh, he's not here. Is it Dixon? This is Romney.
Pavon went down for, he was here, he just wanted to get something to eat and then he's going to be right back.
Oh, yeah,
Oh,
it's
that's
right
nice.
outside.
That's
It's really good.
really?
Yeah.
Yeah.
We'll go on Friday.
Okay.
Like what's?
Yeah,
Yeah,
that's
actually
really
6.
good.
No, he's saying that.
Yeah, they bought it. One dollar.
Will they increase our salaries?
So that's what Dad was saying. Cart must have got more than that.
No, actually,
Just allow you
they
to go
increased
there
it last
weekly
year.
or last.
A couple of months ago.
Oh.
They have them, they do them around Philly, in the city where.
Oh, yeah.
Once a month or something.
No, around the hospital.
Yeah.
Where?
They like pick different locations in Philly. Like, they usually one like Old City, one like South Street.
There's one on the.
Yeah. They just block all the traffic on one. end. So all-
Northern Liberties has one, Chinatown, I think South Street has one.
Yeah,
Old City.
I've been- the only issue is with them, they're
How
all
do you
there.
know? What do you say?
Literally, people like, the food truck
You wish you knew.
Yeah, you wish you
Right.
knew.
Those are everything.
All right, let's get started. I was saying a couple of minutes ago, this is probably my favorite lecture of all time. It's certainly one of my 2. This and consciousness, I was saying. Here's the other one, the frontal lobe. Anyway, the purpose of this lecture is to give you a working knowledge of the pathophysiology of ischemic stroke, because you're going to find that nearly all strokes stroke patients that you take care of are different from one another, and there isn't a simple set of guidelines that you work with. It's more complicated than that. And every stroke patient requires that you be able to think on your feet as you take care of them. So we're going to talk about the physiology of cerebral ischemia. We're going to talk about the imaging that is used to demonstrate the physiology, and then we'll talk about blood pressure management and that sort of thing. I'm going to keep it light on management. We'll see if we have time. Begin with the basic idea, and I think the screen is non-reflectile. No, that works. So begin with the notion that you're dealing with a cardioembolus in a branch of the frontal lobe, okay? And you can see this, the yellow represents a thrombus within the vessel, and the lavender, the dark lavender area is going to represent what we call the core, the ischemic core, and the area around it is going to represent what we call the penumbra, okay? The word penumbra comes from Greek. In shadow technology, if you will, every shadow has two parts. There's a dark part and a light part. The dark part is the umbra, and the area around it in Greek is penumbra, okay? I'm going to tell you a story. This is a true story. This is not just because I know one of the participants. There were 3 neurosurgeons in Sweden in 1977. This is pre-CT, okay? And they're all doing what neurosurgeons do at stroke meetings. They were smoking cigars and drinking brandy and sitting around in the evening. And one of them says to the other 2, hey, you ever do an endarterectomy for a guy that had a stroke, and after you do the endarterectomy, the guy's stroke goes away? And they both looked at him and they said, yeah, we have. And he said, well, what the hell's going on? Okay, that is the beginning of stroke management right there. Because the idea that they conceived was that there must be a threshold. Remember, this is pre-CT. Nobody's ever seen an infarct other than an autopsy. All right. So the idea that they proposed was that there are 2 thresholds for cerebral perfusion. One is the one that we all think of, and that is after a certain reduction below certain cerebral perfusion pressure, tissue is going to infarct, and that's that. But then they said there must be a second threshold below which the brain will not function, which falls electrically silent, and the patient develops a neurologic deficit, but it doesn't produce infarction. And that threshold zone became known as the penumbra. Okay, so that's the idea, is that the umbra is an area of severely reduced blood flow progressing toward immediate infarction, and the penumbra is not. The penumbra is a metastable area, sometimes in long, very long, 17, I had a patient 17 months with a stable penumbra, but usually very meta-unstable. And in the end, and this is from work of one of the Astrup was one of those neurosurgeons, and in 1981, he wrote a letter to Stroke, the journal Stroke, which was just at its beginning, and the letter was entitled, Is Sleeping Beauty Dead? And in that's when the 3 of them proposed this notion of an ischemic penumbra. So we're going to look at the 2, the physiology of the core and the physiology of the penumbra separately, okay? So the physiology of the core begins with the notion that there's a severe reduction of blood flow, less than 10% of what ought to be there. Each region has a different blood flow, intrinsic blood flow. Core is less than 10%. When you get down to that level, there's no glucose going in and there's no oxygen going in. And as you know, the brain requires a continuous supply of glucose and oxygen. It has almost no storage of glucose and it has 0 storage of oxygen. So it requires a continuous supply of both. It cannot use fatty acids for metabolism. It can use ketones if they're present, but they're not usually present unless the person's starving. So when it runs out of glucose and or oxygen, it is run out. Now, what does the brain do with glucose and oxygen? It does all of this glucose and oxygen, right? So what does it do? It makes ATP. Okay, and so what happens when you run out of glucose and oxygen? You run out of ATP. What's the half-life? Here's a question. This lecture has pop quizzes in it. What's the half-life of ATP in the brain after complete cessation of glucose and some oxygen? What's the half-life?
Seconds.
3 seconds. Yeah. 15 seconds, there's no more ATP. What does the brain do with ATP? Yeah, 88% of the ATP consumption is used to maintain the electrochemical gradient, the sodium-potassium disequilibrium. And you should think of that as a battery because it's basically what it is. It's charge separation, it's a battery, okay? So then the question is, all right, when you run out of glucose and oxygen, then in 15 seconds, you're gonna run out of ATP. Then what? What's the ATP for? The ATP is to replenish the battery. So then the battery is gonna start running downhill, right? And at what point does the electrochemical gradient fail? Depending on the region of brain, somewhere between 1 and 4 minutes, okay? And so between 1 and 4 minutes of onset of complete cessation of blood flow, the tissue is going to lose its electrochemical gradient. Sodium, potassium, and disequilibrium goes away. So then what happens? Well, 2 things happen. Number one, the neurons who no longer have an electrochemical gradient, they fall electrically silent. They can't generate any more electrical discharges, no more action potentials. So they're going to stop. That's the first thing that's going to happen. The second thing that's going to happen, though, is when the sodium-potassium disequilibrium fails, water is going to rush into the cell because that electrochemical gradient also is an osmotic gradient and maintains an imbalance. And once that imbalance is lost, water, which has been restricted from outside the cell, is going to enter the cell. The cell is going to swell, right? And that is what we call cytotoxic edema, all right? And that's what's going to happen. And then what's going to happen after that? Electrical silence, shift of water into the cells, and then nothing. Nothing. It just sits there. There's no glucose. There's no oxygen. There are no free radicals because there's no oxygen to make free radicals. There's nothing happening. And then somewhere around 3 hours, you start activating some calcium-activated proteases. White blood cells start entering the tissue, okay? And you start the process of liquefactive necrosis. Liquefactive necrosis doesn't care what the tissue is. It doesn't care if it's a neuron or an astrocyte or an endothelial cell or a smooth muscle cell on the outside of an artery. It's just going to start eating the tissue because it's all going to undergo infarction, and all of it's involved in the infarction. Okay? So that's the process that's going on here. And as a result, the question is, can we safely reperfuse the core? That's the first question that you always have. Because if you reperfuse the core, once this process of infarction is underway, because it includes the arteries, and I can tell you that there are microscopic pictures of staining of elastin, and usually the elastin is in fibrils and it invests the arteries in a complex organized way. But if you look 3 to 4 hours later after as the infarct is starting, and you look in the microscope, the elastin is in balls. It's no longer investing the artery. And you look at the artery, which is denuded of elastin, and you look at it and you go, it doesn't, you just look at it and you go, there's no way that artery is going to tolerate a systolic blood pressure. It no longer has the strength to do that. And when the arterial pressure hits that thing, it's just going to rupture. Okay, so that's the question. That's why this becomes a question, is whether we can safely reperfuse the core. This question has been sitting out there basically since 1981. And only in the last year or two are we really gaining good information about how to do that. But remember that with all of our mechanical thrombectomy and everything like that, that by 6 hours out, at least 50% will not qualify for a thrombectomy anymore. By 24 hours out, 85% of the people will not qualify for thrombectomy. It will be too late. Okay? So let's back up now, all right? And let's look at the biochemistry, the physiology of the ischemic penumbra. Here we have a moderate reduction of blood flow, typically less than 30%, but not hitting that number of 8 to 10%. So this is the threshold that we talked about, all right? It's not going to produce immediate infarction. What's happening under this case is that you're running out of oxygen, okay? But you are preserving the glucose. You still have enough glucose for the tissue to metabolize, but you run out of oxygen. So what percentage, so here's a pop quiz, what percentage of the cardiac output goes to the brain? So the brain represents, all right, here's another question. Brooke, you're from Nikon. What percentage of what's the mass of the brain represents what percent of the body's mass, the total body mass? Yeah, what's the percentage? A lot of questions in there, a lot of information. How big is the brain? Assume that you have a 70-kilo person, okay? How big is the brain? Huh?
Volume-wise or
Wait,
weight?
what, how many in kilos?
Oh, kilos maybe like 1 or 2.
Yeah, 1.4 for a male, probably 1.25 for a female, something like that, but 1.4, okay? So 1.4 is 2% of a 70-kilo person, okay? So 2% of the mass of the body. What's its cardiac output? What percentage of the cardiac output goes to the brain? 20%, right. Why? Because the brain requires a continuous supply of oxygen and avidly takes up oxygen. If you were looking at any other organ in the ICU and you saw an oxygen extraction ratio over 15%, that would mean that that organ is failing. The normal brain has an oxygen extraction ratio of 55%. 55% of all oxygen flowing through the brain, which represents 20% of the cardiac output. More than half of the oxygen is being extracted under normal circumstances. That's not under reduced circumstances, that's under normal circumstances. So it only takes a reduction of probably 50% until you are running out of oxygen. That's given the name the ragged red edge, because it's mitochondrial, so it's the ragged red edge. Okay, and that's where the brain lives. It has no tolerance for reduction in oxygen delivery, none. Okay, when you get down to 30%, then you're going to be running out of oxygen, but you have enough glucose. So what do? Well, if you need ATP and you have no oxygen, but you do have glucose, you turn to anaerobic glycolysis. Now, it turns out that the brain normally runs anaerobically a good portion of the time. There are people who believe that neurons, okay, that the astrocytes never run aerobically. That what happens at the metabolism in the brain is that the astrocyte removes the glucose from the blood vessel and then metabolizes it to lactate, okay, and then hands the neuron lactate, which it converts to pyruvate and then utilizes in the tricarboxylic acid cycle, so that the neuron is never required to do glycolysis, Krebs cycle glycolysis. Okay, that may or may not be true, but it is the case that anaerobic glycolysis is going on all the time. And if you needed to burst, if you went, I don't quite understand, and that region of your brain is working extra hard, it's going to get its ATP anaerobically. It's faster. Anaerobic glycolysis is faster, even though aerobic is more efficient. You can make more ATP faster. If you sprint, you do it anaerobically. Okay? Yeah, because the Krebs cycle is much faster than the tricarboxylic acid cycle. I'm saying Krebs, I mean, I'm the Meyer pathway. Okay, so it turns to anaerobic glycolysis. And the ATP levels remain normal. Okay? So therefore, if the ATP levels are normal, the electrochemical gradient is fine. And that's true. That is, it remains intact. The problem, of course, with anaerobic glycolysis is that you are making lactic acid. Okay? Now, normally, we said the brain doesn't care. First of all, 20% of the cardiac output is running through it. So if it wants to dump lactate into the sewer system, it can do that. It has high flow. But now we're talking about the situation where the flow has been reduced. So not only are you failing to deliver adequate glucose and oxygen, but you are failing to remove the lactate that is being produced at the accelerated rate. And lactic acid's going to accumulate, osmoles are going to accumulate, and the pH of the tissue is going to drop. And the pH can go below pH 4, which is worse than lemon juice. Figure in your finger, that will sting, okay? So this is serious acidosis. This is not 7.07, okay? We're talking, 3.6 pH. So serious acidosis, at which point the tissue falls electrically silent because of the acidosis, even though the electrochemical gradient is preserved because the ATP is normal, okay? But because the electrochemical gradient is preserved, there is no shift of water. Okay? There is no cytotoxic edema in the penumbra. Right? The whole situation is unstable and is going to interact with glutamate and things like that, potassium. And under most circumstances, what will happen is that the penumbra will resolve either into normal tissue or infarcted tissue. And the edge is 400 microns. That's how fine, when you're all done, that's how fine the gradient is between infarction and normal, is less than a millimeter. Okay? So it's going to resolve one way or another. So our goal here, okay, is to preserve the uninfarcted tissue in the ischemic penumbra. Now, you may or may not reperfuse the core. You always need to preserve the penumbra. And so if you don't do this part right, you're not going to be successful in managing the stroke patient, whether you reperfuse them or not. So you're going to have to deal with this part of the tissue, and this is the basis of most of what we do in this step-down unit. Okay? Now, this is a diffusion-weighted image. And the concept of diffusion-weighted image is that, that what we're doing is using diffusion. And the reason that diffusion is useful is because for any element of tissue, let's think about an element of tissue, treating a voxel, okay, on MRI. So a voxel, you're going to average, when you measure the signal in a voxel, you're averaging everything that's in it, all right? And what's in it is cells and extracellular space, right? What's the normal extracellular space of the brain, as far as you know? What is our best estimate? Probably just under 20%. Okay? A lot of extracellular space. When you look under the microscope, you don't see it because the tissue is fixed. So it's water's gone. Okay? So all right. So it's something like this. This is under normal circumstances. Now, what happens in the core? So no inadequate blood flow, no oxygen, no glucose, no ATP, loss of the sodium-potassium gradient, shift of water into the cell, cytotoxic edema. So, okay, so now this is going to look like this, okay? And the cells have now swollen, okay? So what's your ECS? This is the ECS. So the ECS under these conditions is now 8%. So the ECS is smaller. Well, so what? Okay, well, so what is that the diffusion coefficient of water in the extracellular space is the same as the diffusion coefficient of water in a glass of water, which is 3. So it's very fast. This is unbelievably fast. This is Einstein's work, okay? The water inside the cell is like, I always say, is like water in Jell-O. So you pick up a piece of Jell-O, pick up a Jell-O cube, right? It's 95% water. You hold it in your hand, you turn it upside down. It doesn't drip, right? The water, you don't feel the water. You feel that it's wet, but you don't. It's not liquid in your hand. It's a cube of Jell-O. Why? If it's 95% water, because the water is bound to the gelatin. That's what makes it Jell-O. Okay, it's a gelatin. So water inside the cell is the same. Don't we call the cytoplasm the gel, the sol, or that sort of thing? So water inside the cell has a coefficient of somewhere maybe around 0.2. Now, here, what you're doing then, when you make a measurement of the apparent diffusion coefficient in a voxel of MRI using diffusion weighted imaging, is you're taking a weighted average and you get the apparent diffusion coefficient. It's equal to, okay, in this case, it would be, in the normal case, it's 0.8 times 3 plus 0.2 times 0.2, whatever that is. But you can see how much of that is being contributed by this term rather than this term. Now, take it under ischemic conditions. And this number, okay, has now, sorry, it's the other way around. Sorry, like that. Okay, this is the intracellular component. And this is the extracellular component. So even though this is bigger, it's dominated by this term. Now, okay, do this, and you have that. And this term still dominates, but it has gone way down. So when under the ischemic conditions of cytotoxic edema, you're going to have the average diffusion coefficient inside a voxel of MRI is going to plummet. Okay? All right. And so that's what we're going to be looking for. And that's what the radiologists call restricted diffusion. Okay? And that's what it looks like on the diffusion weighted image. All right? So when we do diffusion weighted image, what makes the diffusion weighted image work for identifying the core of the stroke is that it's blind to the penumbra. And it's also blind to old strokes. It's only going to show you active cytotoxic edema. Now, it's good to think in terms of cytotoxic edema because you will see in people who are in status epilepticus, they also develop cytotoxic edema. And you can see the hippocampus on MRI as abnormal. It has certain viral syndromes will give you cytotoxic edema also. Herpes simplex encephalitis will do that. And so anything that gives you cytotoxic edema is going to show up on the diffusion weighted image. In the setting of acute neurologic deficit, that's a stroke, okay? And if you have the pattern, and that's it. And this is how easy it is. We were amazed at the simplicity of this when we were inventing this. I'm one of the inventors of this technique. This was my research in the 90s was on that, okay? And this is what we did. And we were, we worked with the ADC map because we were doing calculations. And we learned that the radiologists didn't like ADC maps. They didn't like numbers. I'm going to hit that again. But also the problem was that the ADC is dark on gray. And dark on gray is physiologically not easy to see. So we reversed it and made it white on gray so that we would be more sensitive to it. This was a physiologic choice that we made. All right. It is extremely sensitive. It's based on this principle of cytotoxic edema. It has a 96% sensitivity. We wrote this in, 1998. And nearly all of the misses were in the medulla. Okay. All right. Now, that's how you see the core. Now, the question though is, how do you see the penumbra? All right. So let's go to that. So I want you to, we're going to look at this. This is an actual perfusion set for one slice on a patient. And this patient has a ICA occlusion on the left side, okay? Picture this guy. So think about the guy in the emergency room, right? He comes in with an acute ICA occlusion, all right? And his NIH stroke scale is 26, something like that. His whole hemisphere is out, right? He's aphasic, he's got global aphasia, he's got a hemiplegia, he's got hemisensory, hemi-neglect, and probably a hemianopia, all of that going on at once, all right? You call his name from the right side, and he's trying to find you in the upper left corner, okay? That's who you're talking about right now. All right, so let's look at this guy. Now, this is to show you perfusion, because that's how we're going to demonstrate the penumbra. Is we're going to find the core, then we're going to find the area of reduced blood flow, And the mismatch, the difference between the core and the area of reduced perfusion is going to be the penumbra. So in order to do that, we have to see the perfusion. This is a perfusion weighted image, okay? And this is how it's acquired, okay? So what you're going to see, because this is the way we think about it, is you're going to inject a dye, the gadolinium, ordinary gadolinium, you're just going to inject it intravenously, all right? It's in the venous circulation, so it has to return to the right side of the heart. It has to go to the lungs. It has to come back from the lungs to the left side of the heart, and then it goes out into the arterial circulation. That takes about 15 seconds, all right? So each of these slices, this is being acquired with a slice time of 1.5 seconds, right? So each of these points represents about a second and a half. Those represent a second and a half. This number 3 is going to be the healthy side of the brain. We're going to look at the kinetics as the contrast comes through. And just because of the way echoplanar MRI acquires a gadolinium signal, it's going to abolish the signal. This is a susceptibility problem. So it's going to abolish the signal. We're going to see the signal go down very fast on this side when the contrast arrives. And on this side, with the ICA occlusion, we're not going to see that happen. We're going to see a delayed start, and it's not going to be very much, and you'll see it, okay? So watch. And this is your time marker right here. Your arrow is your time marker, okay? And we're in the baseline now while it's doing other things. So I'm just whipping through that. All right. And here comes the contrast. And it's in the arteries of the sylvian fissure, right? On the next slide, you see that the tissue itself is starting to darken. See where we are, all right? And it's spreading out from the arteries of the sylvian fissure. These are actual images. These are actual. We're now hitting the ACA and PCA territories, okay? Bilaterally interesting. The guy must have a good circle of Willis, but we're not. Look how we've outlined the left MCA territory, right? Okay, because the contrast is not going in. Right? Now we are in what we would call the capillary phase. We're at maximum signal loss, and it's the tissue's out in the gadolinium is out in the microvasculature. So it's everywhere. But all we have here is a little bit of contrast in some of the proximal vessels of the sylvian fissure on the left side. Maybe a little bit of darkening. Okay? And then this side is now starting to return, but this side is still getting darker. All right? And now this is returning. So the contrast is leaving. It's done. It's perfused through the tissue. Perfusion is not in the big arteries. Perfusion, when you say perfusion, you're talking about the passage of blood through the microvasculature of the tissue. Okay? And here we're a little bit of microvasculature, but really not very much. And then, okay, and then so let's go back. All right, I want to go back. And this is the perfusion of the brain every second and a half. This is what's going on. Right. Now, part of the reason that I make you sit through that is that I want you to realize that perfusion is measured in seconds, real seconds, not milliseconds, not microseconds, seconds, okay? And you could see here how many seconds it took for it to go through the tissue. Here, you know, by 22, 23, it's finished. It starts at 15, and this was all of it. This is most of the tissue. So the next thing that we learned is that radiologists despise kinetic curves, and so we made pictures for them. Okay, this is literally true. Okay, we would have just left it as the curve. We thought that was fantastic to have these kinetic curves. We just looked at the curves and said we could see it all, and we loved it. I mean, we're all a bunch of PhD kineticists playing, and the radiologists, and we hand them these curves, and they go, "Are you kidding?" You know, and we said, "Okay, we'll make a picture." And they said, "Okay." So this is this guy now, all right? These are real people. This is a real guy who's in there. Here's his MRA, okay? He has no ICA, right? He has no MCA, right? Just we said that's going to be the case. Here's his diffusion weighted image. Okay? That's it. This guy's stroke is right there. And that's all. That's his core. Well, that's all there is. The guy's going to have a wrist drop for sure. That's about it. Everything else of the 26 NIH stroke scale points is available for us to recover. Okay? Then why does he have an NIH stroke scale of 26? Look at his perfusion map. Okay? So this was a color-coded map that we made for the radiologist. And the color coding is extremely simple. Dark blue is 2 seconds. Light blue is 3 seconds. Green is 4 seconds. Yellow is 5 seconds. This light orange is 6. The darker orange is 7. The red is 8 seconds. And that's all. And these are the mean transit times of the contrast through the microvasculature of the brain. That's what we're measuring. And it's measured in seconds. Okay? And very quickly we learn that if the mean transit time is over 6 seconds, the tissue is probably going to undergo infarction. Okay? And you can see why this guy would have an NIH stroke scale of 26. So here's another case that we have. This woman had a relatively small, this is the lateral lenticular striate stroke. She has an excellent, it's a bigger diffusion abnormality. She has an excellent outcome. This lady's on TV 3 weeks after her stroke. When she first came in, she had a Wernicke's aphasia, hemianopia. Okay. 3 weeks later, she was back to normal. She was treated in a trial with desmoteplase, actually. Okay. So then what did we learn? And we were one of only 6 centers in the world to have one of these echoplanar MRIs at the time. And everybody said, well, what's the point of this? And we said, well, you'll have one soon. Don't worry about it. But in the meantime, you should be an optimist. Because when we were looking at people 6 hours out, okay, 25% of them looked like this guy that I just showed you. You think I just selected, oh yeah, you must have waited years to find a case like that. The answer is no. A quarter of the people coming through looked like that, where the penumbra was 10 times the size of the core. In another 25%, the penumbra was 3 times the size of the core at 6 hours. Okay, so at 6 hours, 50% of the people, 75% or more of the neurologic deficit is immediately recoverable. We were trying to convince people to give IVTPA. Okay, this is in the beginning of all of this. And the other thing that occurred to that we realized was the time window is nonsense. Okay, it's just a guess that once you have advanced imaging, you don't need time. Time becomes irrelevant. The question is, do you have a mismatch? Because when you have a big mismatch, then you should be aggressive. That was what we were saying. This lecture, by the way, I've updated it yesterday, but this lecture has been more or less intact since about 1998. And it fits with mechanical thrombectomy, why I'm taking my time and doing this with you. So the answer was just get aggressive, be an optimist and get aggressive. When you have a big penumbra, go get it, okay? It doesn't matter how long out you are, okay? And that's the idea. That's what the mechanical, that's what the diffuse and Dawn are showing. That mismatch will persist in some percentage of people all the way out to 24 hours. And if that's the situation of 24 hours, don't worry about it. Just go ahead and treat it. And when I was applying for a job at University of Wisconsin, I was giving this lecture. This was 2001 maybe. And the interventionist came down after the lecture and he said, yeah, if you're so smart, let me show you this. He puts up a guy 17 hours ago, stroke onset, diffusion, perfusion imaging, big penumbra, small core. And he said, yeah, what would you do with that? And I'd say, I'd do thrombolysis right now. And we did. I just put on scrubs and went into the procedure room with him. And we just took care of this guy who did great. I had another guy while I was at Wisconsin who was referred to us with the question of how could this guy have had a stroke and it doesn't show up on CT scan? CEO of a company, right? CEO of a company, babbling idiot, I would say, at the point that I was seeing him 17 months after his stroke with nothing on CT scan. The obvious answer was there was no stroke, okay? This guy had a critical stenosis of his distal ICA. And we just opened it up and he resumed care of his company. He never had a stroke, And that's what Astrup and Tony Strong were saying, and Bruce Isha was the third neurosurgeon. Okay, now, what time is it? Let's just follow. So in just 10 minutes, let's just think about this conceptually now, okay? Because this is what you need to do. The details are, you probably already know the details. So what you want to do is you want to, A, decide if you're going to reperfuse the core, all right? B, and we've been talking about that, you're exposed to that. Let's focus on the penumbra for a moment. The penumbra, the goal here, what's the problem in the penumbra? In the penumbra, the problem is you have a perfusion metabolism mismatch. You don't have enough perfusion to maintain the metabolism of the brain. So therefore, what you want to do is everything that you can do to increase perfusion and everything that you can do to get rid of unnecessary metabolism. Because if you use a molecule of the ATP, you're going to have to restore that molecule of ATP. If you restore that molecule of ATP in the penumbra, you're going to generate another half of a lactic acid molecule. You're going to generate another lactic acid molecule. Okay? And that's the problem. So you don't want to do that. So increasing perfusion is very simple. I said, when again, back in the history of using this, I said, this is what your house staff and this is what your nurses are doing. Right? You're going to increase perfusion by hydrating the patient. This is my rule of thumb. This is how I hydrate a patient. I give 1.5 mils per kilo per hour. So a 70 kilo person gets 100 mils an hour. 80 kilo person gets 125 mils an hour. In the absence of any reason not to give saline, this is the best approach. Is just give normal saline, okay? And it will support the blood pressure as well. And that's from the other thing, is you want to hydrate the patient, you want to maintain the blood pressure in the best range. Now, what is the best range? Empirically, it has been shown that if you don't do thrombolysis, that the patients will do best when their perfusion, their mean arterial pressure, is 105 to 120. So we use the MAP because the MAP is the one that correlates with perfusion, not the systolic or the diastolic, but the mean arterial pressure is what correlates with perfusion. So you set your target as a MAP, and above 120, you start creating injury. You start breaking the blood-brain barrier and that sort of thing. So you don't want to be there, okay? But otherwise, you want to be as high as possible, and you want to give the nurses a reasonable range, and so you target 110 to 120, okay? Now, that's if you haven't done thrombolysis. If you have done thrombolysis, then your problem is no longer perfusion because you've done the thrombolysis to deal with the perfusion. Now the problem is you need to avoid a hemorrhage. Can you safely reperfuse the core without creating a hemorrhage? So you need to prevent the hemorrhage from occurring. And the way that you do that is you focus on the systolic blood pressure and you keep that below 160. Okay? This lecture is 20 years old, okay? It's the same as we're doing today. If we said, what's your blood pressure guidelines to prevent expansion of an intracerebral hemorrhage, what would you say? Keep the systolic below 160 is the answer. This is nothing, none of these things have not changed, okay? When we increase blood pressure, the easiest way to increase blood pressure in most stroke patients who are older is to give them normal saline. And when you give them normal saline, they don't tolerate IV normal saline all that well, so their blood pressure goes up, and that's what you want. In a young person, I used to talk about a 36-year-old woman who had a PFO. She was arguing with her son over the car keys, and right in the middle, she was an aerobic instructor. She was like a horse. She was, and right in the middle of arguing with her, she developed hand clumsiness and weakness, and she said to her son, "Oh my God, I think I'm having a stroke." She ran, and I mean literally, she didn't bother with the EMS or anything. She ran to the hospital, okay? Presented to the ER and said, okay. Now she was, by the time she got to us, a canoe turned over in Peconic Sound and that kind of day. And by the time she got to us, she was way outside the IVTPA window, even though we had a helicopter. So we had her all night long with an occluded M2. All right. And we gave her normal saline to raise her blood pressure, and it didn't go up 2 millimeters of mercury. She just started to pee. So we increased the rate of normal saline, and she peed more. Okay. And we never raised her blood pressure. Finally, and she wasn't doing well. So finally, we just put her on a pressor. And that's what we've done ever since. And the good news is that the elderly, who would probably not tolerate the pressure all that well, go up when you give them normal saline. And the young person whose blood pressure will not go up with normal saline tolerates the pressures perfectly well, or have a healthy young heart. So this is a nice trade-off for us, and so we do one or the other. To decrease the blood pressure, the first thing you want to do is look and see if there's a reason that the blood pressure is elevated. So I'll give you an example. Everybody's real. You don't need to make people up. There's plenty of real. So this guy comes in, 55-year-old right-handed white male, comes in with acute onset of a global aphasia, all right, and a mild right hemiparesis and facial. So his blood pressure was about 110/70. He was an atherosclerotic patient, carotid occlusion, not hypertensive guy at all. So we started to give him normal saline. As soon as we gave him normal saline, his pressure came up into the range that we want, and we're giving him about 125, 150 an hour of normal saline. We have him in the ER for 3 or 4 hours, and his pressure starts going up. I mean, going up. So we turn off the normal saline, and his pressure continues to go up. The guy's sweating. Okay, I mean, he's starting to look really bad. We're going and getting medication to bring his blood pressure down. What's going on? So what's going on is he needs to pee, and he's aphasic, and he can't tell us. And he's got a full bladder, and the full bladder is driving his pressure up. So we looked at him and we thought about it, and we said, shit, he's got 700 mils of normal saline in by this time. Okay, we put a Foley in, get out 450, and his pressure just comes down. Okay. Another example of real people was, I remember a nun was helicoptered to us at Madison, University of Wisconsin, helicoptered to us with an acute stroke. She comes into the ER, she is shaking. I mean, she's shaking, this 70-year-old, 50-kilo woman. She's just shaking in there. And the nurse from the ER, and her blood pressure was 220 over 120 or something like that. And the nurse just walks over to her and she leans on the stretcher and she goes, hell of a ride, wasn't it, honey? Like that. And then the nun just started laughing and her blood pressure just came down. She was just so nervous and the nurse did exactly the right thing. She just made a joke and we never treated her with anything. So you have to look and see if there's a reason. Look at the patient, see if there's a reason. If there is, fix it. We're pretty much standard again for the last 20 years is you give 10 to 20 of labetalol every 5 to 10 minutes. Then we learn by the second dose of labetalol, you might as well mix or bring the nicardipine to the bedside and use your nicardipine. Okay? I don't want to get any, let's look at reducing unnecessary metabolism. So that's all you need to do to increase perfusion. Hydrate the patient and get the blood pressure right. On reducing unnecessary metabolism, let's start with this. You don't want to tolerate, what's the problem in the penumbra? What's the fundamental chemical problem of the penumbra? Well, it's acidosis, but that's not the primary, that's a secondary problem. That is what's creating the deficit. But why? What's driven the acidosis? Yeah, the anaerobic state. So there's an hypoxia in that tissue. So number one, we're not going to tolerate hypoxia, okay? And hypoxia for our purposes will be defined as anything less than 96%. So if they're at 98% on room air, it suits me, then they don't need oxygen. If they're at 94%, I want them, then they need some nasal oxygen. Or whatever you need to do to bring them up. Don't tolerate hypoxia. That will increase, right? That's going to increase the metabolism in the penumbra, which you don't want. You want just the right amount of glucose. And here, this is a challenging question because on the one hand, right? So think about the penumbra. Come on, pop quiz. What's the difference between the core and the penumbra biochemically? What's the difference between core and penumbra? They're both running out of oxygen. What's the difference? Yeah, so you have glucose going, you have adequate glucose yet in the penumbra, which you don't have in the core. So at some serum level of glucose, and it's metabolizing the glucose fast, anaerobically. This is not normal glucose. And remember that the glucose serum to brain is a passive facilitated diffusion. So the brain's glucose is only 2/3 of the serum glucose. Under any circumstance, it's going to be, that's all that you get. Okay, it's facilitated, but it's passive. There's nothing driving it. Okay, so therefore, if you lower the glucose at some level, you're going to drive the penumbra into core biochemistry. So you're going to have to maintain the glucose. On the other hand, the problem in the penumbra is the anaerobic glycolysis is creating a lactic acidosis. So if you just let it run unrestrained, you're going to make the tissue more acid. And so it was an empiric question about where you want your glucose to be. And the answer is between 100 and 130. And we don't use insulin infusions here very much, but I can tell you that at Stony Brook and Wisconsin, we use insulin infusions probably in a quarter of our stroke patients. We did it all the time. We nailed them. We put them in the 100, 130 range. We clamped them in there. We did that. And then finally, you need to avoid hyperthermia. And this is not taken seriously in the ICU. Okay, it's one of the reasons that I don't like stroke patients in the ICU. They don't get this. Okay, it doesn't matter how many times we tell them, they don't get it. 2 degrees centigrade, we're in centigrade here. 2 degrees centigrade doubles infarct volume. That's in humans and in animals. 2 degrees centigrade, going from 37 to 39. Brain, remember, is at 39, right? Our body's at 37, our brain is at 39 right now. Normal, healthy brain. What evolutionarily, what allowed Homo sapiens, all the Homo species to develop, was the skull became a radiator. Okay? You want to find someone who's lost in the woods, take an infrared camera and go look for the radiation of heat out of their skull. If they're wearing a hat, it's a problem. Okay? I mean that. That's how you search for people. Okay? Because that's how much heat is coming out of your skull all the time. And until the diploe of the skull developed, the brain could not increase its size because it kept frying itself. So it runs hot. There's all this metabolism is hot. This is real. This metabolism is real. So 2 degrees centigrade doubles the infarct volume. You go, that's a fever. I don't really want to care about that statistic. Think about this one for a minute. 1 degree centigrade maintained for 6 hours. That's 38 degrees. Not even a fever workup. 38 degrees for 6 hours. Doubles the likelihood that the person never goes home. Okay? That they either die or go to a nursing home permanently. It's 6 hours at 38 degrees. So this is serious, okay? And when we say that we want temperature controlled with Tylenol anytime above 37.3, we're not kidding. We mean it, okay? And the nurses here get that, okay? The nurses in the ICU, it's 37.7. It's like, yeah. Is the patient febrile? No, he's 37.7. No, he's only 38.1. Okay, it's like, that's not good. I think that we're probably done. Yeah, it's 1 o'clock, so I'll stop. The reperfusing the core is. Let me just show you one slide. This is the only slide. This comes from John Marler, who was head of the NIN-CDS at the time that TPA was being introduced. And you got this 3-hour window. And the rule of thumb for IV TPA is this, that if you give IV TPA within 3 hours of onset of stroke, you increase the likelihood of a good outcome by 50%. Back up and explain that. This is where, okay. So here, look at the modified Rankin. So good outcome. So goes up by a relative 50%. 26 becomes 39% of independent outcome. Okay, that was the basis for the approval of IV TPA in 1995. That's what the NINDS study showed. This, okay, and it increased the rate of hemorrhage tenfold, but nobody cared because it didn't change the rate of death. These people, whether they herniate or whether they hemorrhage into their brain, it's like, I kept saying, who cares? I don't care why the patient dies. If he dies, he dies. The reason doesn't matter. And so there was no downside to giving the IV TPA. There was only the upside of 50% increase in the number of good outcomes if you give the IV TPA within 3 hours. And then John Marler looked at that. So that, in other words, that means, put it another way, that the relative benefit of IV-TPA is 1.5, right? That's your relative benefit is 1.5 if you give IV-TPA within 3 hours. And we're all working with that in our head. And then John Marler, who was accumulating all the data from all over the country, said, you know what? It's more complicated than that. So yeah, for everybody in 3 hours, the relative benefit is 1.5. But look at this. Look at the data now that I've got all this data. Let me show you what happens. Let's look if you give the IV-TPA within 1 hour of stroke onset. What do you get? You get a relative benefit, not of 1.5, but of nearly 4. Nearly 4, okay? A number needed to treat of like less than 2 to have a benefit when you're under 60 minutes, okay? Come out to 90 minutes, and you're still dealing with a relative benefit of 3, which is really nice, okay? Come out to 120, 2 hours, and you're dealing with a relative benefit of about 2.5, okay? Go out to 180 minutes, and this is the benefit line, these are confidence limits, and your benefit is 1.1 or 1.2. Well, that's partly because of where this line was set, this horizontal line. So as we learned about glucose control, which we didn't know in 95, and as we learned about how to prevent hemorrhages, and nicardipine was introduced, which it wasn't when this study was done. When all these things did, so this line came down a little bit, at which point this line wasn't crossing the threshold line until 4.5 hours. And that's when they expanded the window from 3 to 4.5 hours. But you're still in this asymptotic portion of the curve. And so the relative benefit is very marginal after 3 hours still. Which is why after 3 hours, we even in 1998, we were going to mechanical thrombectomy. Even if we could do it, we would prefer mechanical thrombectomy. Okay? So let me just, so any questions before we break? I'm not going to say anything else. Yeah?
Anyone say cooling on these issues?
So far, that has not been shown to be a benefit. We are going to start an experiment on that momentarily. But not right now. There's no one who's been able to improve stroke outcome with cooling. We are going to double down on that very shortly. We have a cooling device that is an interventional cooling device which will cool the cerebral hemisphere without dropping body temperature. And we intend to bring the cerebral hemisphere temperature down to between 22 and 25 degrees for some period of time. I don't know, that will be part of the experiment. The dose response curve with this catheter. And then continuous EEG monitoring, probably hemispheric biochemistry being done. We're going to get pretty sophisticated very shortly. We're gearing up for that right now with perfusion imaging, of course. Okay, any other questions? So you get the concepts, core, penumbra, the biochemistry of the core, the biochemistry of the penumbra. You need to apply this. You need to apply it as you're taking care of the patients. You need to be thinking about what you're doing. Where are they? When you get your diffusion imaging, or when we eventually introduce good perfusion imaging here, you're going to start to use that. When you have it, because you won't always have it. A lot of times you're going to be moving faster than you don't want to take the time. No, I'm not a big fan of taking a lot of time for further imaging in acute stroke. Okay, good.